Hello friends, I am Dr. Farheen, your OBGY faculty at Aakash PG Plus. Let's start the second innings of INICET 3030. Your time starts now. The first question is, all are causes of ectopic pregnancy except the highest risk factor is seen when the patient gives a history of a previous ectopic pregnancy. The second highest risk factor is if she has had any tubal surgery. Other risk factors include prior history of any tubal infection, any tubal adhesions, artificial reproductive therapy, and in contraception, the highest is with progesterone IUCD, followed by copper T and progesterone only pill. What does progesterone do? It decreases the tubal motility. So going through the options, all are causes except IUCD, it is a cause. Previous tubal surgery, yes. Previous ectopic, definitely, this is the most common cause. Combined oral contraceptive, no, it is progesterone only pill. Another important thing about ectopic, the most common site is the ampulla. And what is the earliest to rupture? The earliest to rupture is isthmus because it is the narrowest portion. Pseudosac is seen in. Pseudosac is the pathognomonic sign of ectopic pregnancy. What do we mean by that? So this is the uterus. We can see an echogenic uterus over here and exactly in the center of the uterus. It is not eccentric. Had it been eccentric, it would have been here. It is exactly in the center of the uterus. We can see a mass which has irregular edges. So this is typical of a pseudo-sac and ectopic pregnancy. Had it been a normal pregnancy, the mass would have been eccentric and the margins of it would have been smooth. Also, the first sign seen in intrauterine pregnancy is the intradecidual sign, and we can also see a double decidual sign. So your ectopic pregnancy is the answer. Another thing which is commonly seen in ectopic pregnancy is the ring of fire or the donut or the bagel sign, and this sign is also seen in a corpus luteal cyst. Coming to the third question, a second gravida presents a 6-week period of gestation to OPD with complaints of shoulder tip pain. Her vitals, as we can see here, is unstable, and ultrasound is showing fluid in the pouch of Douglas. So this is a clear-cut case of a ruptured ectopic pregnancy. How do we come to diagnosis? Shoulder tip pain is because of the blood, which is irritating the diaphragm, and this is leading to a referred shoulder tip pain. And in ultrasound, if it is showing fluid in pouch of Douglas, which means that the tube has ruptured, and this is a pathognomonic sign of a ruptured ectopic. So there is a very simplified chart over here how to deal with ectopic pregnancy questions. If the patient has a ruptured ectopic, if there is cardiac activity present in the gestational sac, if the patient is hemodynamically unstable, please do not think about anything else, no GSAC, no beta HCG, you will directly go for salpingectomy. Okay. If the patient wants to preserve her fertility or the other side of the tube has been operated upon, then only you will go for salpingostomy. Otherwise, the surgery of choice is salpingectomy. Okay. So going back to the question, will we do laparotomy and salpingostomy? Let's come back to this. Do laparoscopy. Since the patient is unstable, we will not do laparoscopy. Will you give methotrexate? No medical management because she is unstable. It's a ruptured ectopic. Salpingostomy versus salpingectomy, we will definitely go ahead with the salpingectomy. Had they mentioned that the other side of the tube has been affected or the patient does not have the other side of the tube because of the prior ectopic, then only we will go for a salpingostomy operation. Am I clear? Now question number 4, a second gravida at 6-week period of gestation comes through OPD, her vitals are stable, cardiac activity is absent, ultrasound shows a gestational sac of 3 cm in the right adnex. Beta HCG is 4000. What all can you do except? Okay. So, is she a case of ruptured ectopic? No. The cardiac activity is absent and she is hemodynamically stable. So, the next thing that we will see in this patient is the gestational sac size and the beta HCG value. So when all can you do an expectant management? It means when all can you wait and just watch? So when the serum beta HCG is less than 1000 and the gestational sac is less than 3.5. And when can we do medical management? We can do medical management up to the beta HCG value of 5000 and the sac size of up to less than 4 cm. Again going through the question, although the sac size is 3 cm, but the beta HCG value is 4000, right? So what all can we do? Can we do a salpingectomy? We can do, the patient can always opt for a surgical option. So salpingectomy and salpingostomy can always be done, right? Methotrexate, yes, she's an ideal patient for medical management. Can you do expectant management? No. Because although the sac size is less than 3.5, but the beta HCG is 4000. And what is the limit for expectant management? 1000. So therefore, the answer of choice is expectant management. Now, few points about methotrexate. Before giving methotrexate, we have to do a serum beta HCG level because basis that only we are going to monitor the patient, right? Also, we have to do a CBC count of the patient. We have to do a renal function test and liver function test because it tends to affect the liver and the kidney. We also need to do a blood grouping and RH typing of the patient, because if the patient is RH negative or ICT negative, we need to give antidote to the patient. So day 1, again, we will do serum beta HCG and we will give intramuscular methotrexate 50 milligram per meter square. Day 4, we are just going to take the sample of serum beta HCG. Day 7, again, we will take the sample of serum beta HCG. Now, if between day 4 to day 7, the beta HCG decrease is by more than 15%, then we will repeat the beta HCG weekly till the values go less than 10 international unit per liter. Okay. But if there is no decrease in beta HCG between day 4 to day 7, then we can repeat a second dose of methotrexate on day 7. Alright. You can also give option to the patient for go ahead with the surgical management. Another very important point, if we have given methotrexate to the patient, then we ask her to avoid pregnancy for 3 months. Another point I would like to add here, that methotrexate is also given for molar pregnancy if it is given in a multi-dose regimen. So then we ask patient to avoid conception for 1 year. This is a very important point. Okay. Now, fifth question, patient presents to OPD with 2 months of amenorrhea. She is UPT positive. She is pregnant. No gestational sac is seen on the ultrasound. Vitals seem to be stable. Beta HCG is 600. How are you going to manage this patient? Okay. So there is no gestational sac. So we all know that the beta HCG doubles after every 48 hours. So we are going to do a serum beta HCG level, repeat it after 48 hours. Now there can be 3 scenarios. Okay. If it is falling by more than 15%, the baseline level and the second day level, then then the likely cause can be abortion. And for how long do we need to monitor the patient? We will do weekly serum beta HCG levels till the value go less than 10 international unit per liter. Okay. The second is, if the beta HCG is doubling, has doubled between day 0 and day 2 by more than 66%, then most likely it's an intrauterine pregnancy. Again, we will do weekly beta HCG till the levels go more than 2000. Why more than 2000? Because that is the discriminatory zone. And on TVS, we can see a gestational sac when the beta HCG is more than 2000. And on TS, what is the value? TS, the value is more than 6500 international unit. The gray zone is when the values are not falling by more than 15% and it is not doubling by more than 66%, and that is the gray zone. What do we need to do then? It is most likelihood that it can be an ectopic pregnancy. So we will monitor the serum beta HCG till it reaches 2000 international unit, or it can also happen that it has plateaued. So if there are 3 plateau levels, or it has reached more than 2000, then we will repeat a TVS. If it is still negative, then we will go ahead with methotrexate. So coming back to the question, repeat ultrasound after 48 hours? No. Give methotrexate? Not right now. Repeat beta HCG after 1 week? No. We are going to repeat beta HCG after 48 hours. Now the next question, what if the same patient presents to OPD? Here we can see that her beta HCG values have been taken on day 0 and day 2. The day 0 value is 450, day 2 value is 280. What is the most probable diagnosis? So we know that the fall is by more than 15%, right? So what can be the most likely diagnosis? It's an abortion or a failing pregnancy. So this is your answer. Another scenario, day 0 and day 2 sample show that beta HCG is 350 and on day 2 the sample is 600. So how are you going to manage her? We can see that the beta HCG has doubled by more than 66%. So what are you going to do? It is most likely an intrauterine pregnancy, and we will continue monitoring beta HCG weekly till it reaches 2000, right? So going through the options, we will repeat beta HCG weekly till it is more than 2000. Next question, an 8-week second gravida with previous LSCS presented with spotting per vagina. Transvaginal sonography showed cesarean scar pregnancy. What is the best management? Before going through the option, let's see what is cesarean scar pregnancy. So here what is happening, that the ectopic is forming on the previous scar. This is the uterus. This is the bladder which is filled with urine. Here is the previous scar. We can see this is the previous scar and the pregnancy is lying on the scar. So the most common symptom of this is that the patient will have painless vaginal bleeding. It is a very life-threatening condition. The complications include uterine rupture, there can be massive hemorrhage, there can be preterm labor, placental complications, and it has very high maternal mortality rate. So what is the investigation of choice? Investigation of choice is transvaginal sonography and color Doppler, where we can see a lot of vascularity along the previous scar site. What is the management? Best management is laparotomy with excision of the gestational sac. Also, if the cardiac activity is present, then we can give intramuscular or intragestational methotrexate. So going through the options, give methotrexate orally? No. Give intragestational sac methotrexate? Yes, it can be given. Confirmed diagnosis by MRI. Now, TVS is the investigation of choice, followed by color Doppler. Just in case if it is inconclusive of both of these, then only we will go for MRI. If it has been confirmed by TVS, no need to go with this. Alright. Excise the GSAC by laparotomy. This versus this, we will always prefer option number C. What is the investigation of previous scar site ectopic? It is color Doppler. What is the criteria for diagnosing abdominal pregnancy? This is a very often asked question. So it is the study Ford criteria. You just need to mug up this table. For abdominal, it is the study Ford criteria. For the cervical pregnancy, it is the Rubin's criteria. And for the ovarian pregnancy, it is the Spiegelberg criteria. All are the functions of amniotic fluid except. So let's go through the properties of amniotic fluid. It is faintly alkaline. pH is 7 to 7.3. It has a low specific gravity. It is hypotonic at term. We need to remember this. Osmolarity is 260 milliosmoles at terms and it decreases with age. This they have asked as a question. It contains mainly water, 98 to 99%, lanugo, some epithelial cells, vernix caseosa. Very important point that it has no nutritive value. The nutritive value is only given by the placenta. So coming back to the question, it has bacteriostatic properties, yes. It helps in development of GIT, yes. It prevents trauma to the fetus, yes. It acts as a cushion. Is it a major contribution of nutrient to the fetus? No. So this will be your option of choice. In comparison to maternal plasma, the osmolarity of amniotic fluid is, we have remembered, it is hypoosmolar. So the osmolarity is 260 milliosmoles. Maternal plasma has 280 milliosmoles of osmolarity. Another favorite question is on the color of the amniotic fluid. So at term, it is straw colored. If it's a preterm, it is colorless. Placental abruption because there's a lot of blood, so a dark blood stained color. Intrauterine death will lead to tobacco juice color. Post maturity, there will be saffron color, and in RH isoimmunization, it is golden colored. The main contributor of amniotic fluid after 20 weeks of gestation is, okay, so before 20 weeks, it is the fetal skin. The fetal skin gets keratinized by around 20 to 25 weeks, but it contributes to the amniotic fluid only till 20 weeks. Remember this. Although the fetal kidneys start producing urine by 12 weeks, but they contribute to amniotic fluid only after 20 weeks. Okay, so before 20 weeks, it is the skin, and after 20 weeks, it is the fetal urine. And when is the volume of amniotic fluid maximum? So volume of amniotic fluid is maximum between 34 to 38 weeks of period of gestation. It is up to 1000 ml. This is also a very favorite question. And after this, it goes on decreasing. So your answer will be, since they have asked after 20 weeks of gestation, so it will be fetal urine. So what is the AFI index for diagnosing oligohydramnios and hydramnios? Polyhydramnios is also known as hydramnios. So what is this is something which you just need to mug up. Normal AFI is 5 to 25 and the single depth pocket is 2 to 8 centimeter. If it is oligo, then it will be less than 5. The single depth will be less than 2 and the total LICA will be less than 200. If it is polyhydramnios, then AFI will be more than 25. Single depth will be more than 8 and the total LICA will be more than 2000 ml. Okay. So AFI less than 5 and poly is AFI more than 25. All are causes of polyhydramnios except. So the most common cause for a polyhydramnios is idiopathic. Remember this. If this is not in the option, then GI anomalies of the fetus followed by the other causes like tracheoesophageal fistulas or CNS anomalies. In mother also there are few conditions which can lead to polyhydramnios. The most common of them are diabetes mellitus, RH isoimmunization and TORCH group of infections. So coming back to the question, all are causes, TORCH is the cause? Yes. GIT anomalies? Yes. Tracheoesophageal fistulas, yes. Bilateral multicystic dysplastic kidney will be the option. So just remember one thing, wherever kidney, any problem with the kidney is there, it will always lead to oligohydramnios. Okay. All are causes of oligohydramnios except. So the most common cause of oligohydramnios is the urinary tract anomaly, because the major contributor after 20 weeks is the urine. So any problem which is there with the bladder or the urine. So there can be renal agenesis, multicystic dysplastic kidney. You need not remember all the terms. Just remember this thing, that anything which is related to the kidney will lead to oligohydramnios. Infantile polycystic kidney disease or a posterior urethral valve, very important. So preterm premature rupture of membranes. Since the membrane has ruptured, the liquor has flown down, so it can lead to oligo. Kidneys involvement, yes. Posterior urethral valve, yes. Prematurity, can it cause oligohydramnios? No. In fact, with post maturity, there will be oligohydramnios. So this will be our option. Keyhole sign on ultrasound is seen in. This keyhole is pathognomonic of a posterior urethral valve. Okay, we can see that this is like a keyhole of the door, right? Where we insert our key. So this is the keyhole sign, and this is pathognomonic in a posterior urethral valve. Porter's sequence is seen in all of the following except. So what is this Porter sequence? What happens that there is bilateral renal agenesis or bilateral multicystic dysplastic kidney, any problem with the kidney. Since there is a problem with the kidney, there is decreased fetal urine excretion, there is oligohydramnios. Now, since there is oligohydramnios, there is no fluid around the baby cannot grow that well, and everything is going to be compressed. So there will be pulmonary hypoplasia, the faces of the baby will be compressed, the limbs are going to be contracted, and there will be bilateral renal agenesis. So coming back to the question, bilateral polycystic kidney disease, yes. Renal agenesis, yes. Early premature preterm prom, yes. Tracheoesophageal fistula, well, this is a cause of polyhydramnios, right? Not oligohydramnios. So therefore, Porter sequence, this will be the answer. Going to the next question, what is a low birth weight baby? So it's a very direct question. Low birth weight baby is when the weight is less than 2500 grams at any gestational age. Now remember, this is very important. If the baby is born at 30 weeks, or if the baby is born at 38 weeks, or if the baby is born at 28 weeks, unlikely. And if the weight is less than 2500 grams of all these babies, then all of these babies will be low birth weight babies. So this is irrespective of the gestational age. Okay. Now there is this another term, small for gestational age. It is when the weight is less than 10 percentile for that gestational age. Okay. So it means, what do we mean by less than 10 percentile? That the baby is smallest 10 out of 100 babies. So what is low birth weight baby? Weight is less than 2500 grams. All is seen in a constitutionally small baby except. Okay. So before that, what was small for gestational age baby? The baby which was smallest 10 out of 100 babies. Okay, so if we were to take 100 babies, our baby is falling in the smallest 10 babies. Okay, smallest 1 to 10 babies are a small for gestational age baby. Now these small for gestational age babies, there can be two things in them. They can either be constitutionally small, which means that there is no pathology, it is just that they were meant to be small because of the genetics. Okay, or there can be any pathology because of which is they are small. So if any pathology is there, then they are called as growth restricted baby. Okay, so if there is no pathology, they are constitutionally small babies. These are healthy, the blood flow is normal, the placenta is working perfectly. These are small for gestational age baby, but they are growing at a normal pace. So suppose this is the growth chart of the baby. This is the 90th percentile. This is the 50th and 10th. So less than the 10th centile. So both constitutionally small babies and IUGR or growth restricted babies both fall under the small for gestational age. What is the difference? We can see that the constitutionally small baby, although it is less than 10th centile, but we can see that it is growing at its pace. But a growth restricted baby, we can see that the growth is somehow static and it is moving very slowly. So this is a growth restricted baby, and it is because of some pathology. So all is seen in a constitutionally small baby. Let's go through the option first. Baby is healthy, yes. Growth of the baby is normal, yes. Placental flow is normal, yes. Weight is more than 10th centile, no. It's a small for gestational age baby, so the weight is less than 10th centile. All are seen in IUGR babies except. So coming back to the discussion, What are the causes of a growth restricted baby? There can be placental problem. The placenta is not functioning that well because of hypertension, preeclampsia, APLA. There is any maternal condition like diabetes, anemia, or chronic kidney disease, any infection in the mother, TORCH group of infections, or chromosomal anomaly. So this IUGR can further be a symmetrical IUGR where the baby getting affected from the early gestational age, and an asymmetrical IUGR where the baby is getting affected at a later gestational age. So which of these are going to have a better prognosis? Obviously when the baby is getting affected at a later gestational age, right? So this one is going to have a better prognosis. Now, in the symmetrical IUGR, since the baby is getting affected from the very beginning, so the head, abdomen, everything is going to be small, and therefore everything is going to be in symmetry. Okay. In late onset IUGR, what will happen? That the head will be enlarged, but the abdomen is not going to be enlarged that much. So therefore, the head circumference is to abdominal circumference, and femoral length by abdominal circumference is going to be elevated. Why? Because the abdominal circumference is low in these babies. Howsoever, in a symmetrical IUGR, it is going to be normal. Another very important point, ponderal index is going to be low. It is birth weight by crown rump length. In this, since it's a symmetrical baby, so the ponderal index is going to be normal. Okay. So everything is normal in a symmetrical IUGR baby, but the prognosis is bad. Why? Because the baby has been affected early in the condition, mostly because of a genetic disease. And asymmetrical IUGR is mostly because of a uteroplacental insufficiency. So coming back to the question, IUGR baby has all except weight is less than 10 centile. Yes, it's a small for gestational in baby. Pondered index is normal. It can be symmetrical or asymmetrical. So if it's symmetrical, it will be normal. It is associated with uteroplacental insufficiency. Yes. HC by AC ratio is low. No, it can never be low. In symmetrical IUGR, it will be normal. And in asymmetrical IUGR, it will be high. What is the best parameter to diagnose IUGR? So the best parameter to diagnose IUGR is your abdominal circumference. A second gravida presents at 30 weeks of period of gestation. Her symphysiofundal height is 26 centimeter. The ultrasound report is attached here with. How are you going to evaluate her? So let's see the biometry. How are we going to monitor this patient? First of all, you're just going to see the abdominal circumference. So she's a 30-week patient. This symphysiofundal height should actually correspond to the number of weeks. So it should ideally be 30 centimeter, but here it is 26. Let's see the abdominal circumference. As per the abdominal circumference, the baby is 26 weeks period of gestation. So this is definitely a small for gestational age baby. We can see it is not growing that well. So how are you going to further evaluate her? Okay. So we are going to repeat biometry in this patient after 3 weeks. Okay. We know that this is a small for gestational age baby, but we just need to know whether it's a constitutionally small baby or there is some problem with the baby, it is growth restricted. So therefore, to confirm that, we will repeat ultrasound after 3 weeks. If after 3 weeks, her period of gestation will become 33 weeks, right? From here, and the abdominal circumference is 31 weeks. It means that the baby is somehow growing because earlier it was 36 weeks. So it's a constitutionally small baby. There can be a second scenario that we repeat the ultrasound after 3 weeks and we find that although the period of gestation is 33 weeks, but her abdominal circumference is now 29 weeks only. It means that the growth is majorly restricted and it's a growth restricted baby. How are you going to confirm this? You are going to confirm this by Doppler studies. Okay. So to simplify this, first we will do symphysiofundal height monitoring. After that, we will do biometry, which is the ultrasound. On the biometry, if we find that there is some problem with the growth of the baby, we will repeat the biometry after 3 weeks, where we will get to know whether the baby is constitutionally small or growth restricted. If it is growth restricted, then we will go for Doppler. Alright. Question number 22. A second gravida at 35 weeks period of gestation, diagnosed case of IUGR presents with absent or reversed end diastolic velocity. How are you going to manage this patient? Okay, so let's go through the chart first. First of all, what we were doing, symphysiofundal height, right? After that, biometry. We got to know that's a small for gestational age baby. We repeated it after 3 weeks. We confirmed that it's a IUGR baby and then we went for Doppler. Okay. Now, since we know that it's a IUGR baby and we have started doing Doppler, from here onwards we will start. So we'll do the umbilical artery Doppler. If it is normal, then we will repeat biometry and Doppler every 2 weekly. Okay, so it is done every 15 days. and we will plan delivery by 37 weeks. Okay. If there is some problem with the Doppler velocity just measures the amount of blood which is going from the placenta to the fetus. So ideally there should be a forward flow, right? It should go from mother to the fetus. But absent or reversal means that the blood is either has stopped going from the placenta to the fetus, which is absent, or reversal means all the more bad prognosis that the blood is flowing from the fetus into the placenta. Okay. So this is what we mean by absent, reversed, and diastolic velocity. So if there is absent or reversed end diastolic velocity, it's a very bad prognosis. We will plan delivery if the patient is more than 34 weeks. If she is less than 34 weeks, we will give her steroid. We'll wait for the baby's lung to mature and deliver the patient. Okay. Now, if it is not absent or reversed end diastolic velocity, but there is some problem with the Doppler flows, the blood is not flowing as well as it should be in layman terms. So what will we do? We will do the Doppler weekly, and we will do the biometry twice weekly. What is biometry? Your BPD, head circumference, abdominal circumference, femoral length. Okay. And we will plan the delivery of this patient again by 37 weeks. If we see that the growth is static, or there is some additional problem, or there is some worsening in the Doppler flow, then only we will deliver the patient prior to 37 weeks by giving steroid. So the time of delivery is always 37 weeks. If the baby has to be delivered at less than 34 weeks, then we will give steroid. So coming through the options, give her steroid and deliver the patient. She is 35 weeks and we can deliver her immediately. Okay, so this will be the option. Repeat Doppler to confirm the diagnosis, not needed. Give her steroid and deliver at 37 weeks, no, when she is presenting with absent, reversed, and diastolic velocity. What is the most common chromosomal anomaly leading to spontaneous abortion? This is the most common. And what is the most specific? Again, a very direct question. So the most common condition which leads to a spontaneous abortion is your chromosomal abnormality. In that chromosomal abnormality also, the most common is your aneuploidy. Aneuploidy means increase in the number of chromosome or decrease in the number of chromosome. So in aneuploidy also, what is the commonest? Increase in the number of chromosome. So trisomy. Okay. In trisomy also, what is the commonest? Trisomy 16. So the commonest is trisomy 16. If that is not in the option, trisomy alone. If that is not in the option, then aneuploidy and or chromosomal abnormality. But if they were to ask what is the most specific chromosomal abnormality, then it is monosomy X or the Turner syndrome. So therefore, our answer here is trisomy 16 and here it is your Turner syndrome. Question number 25. A primary gravid at 8 weeks presents with pain in abdomen, bleeding per vaginum since 4 hours. On examination, uterus is 6 weeks, os is open. What is the diagnosis? Okay. So before going through the options, let's remember just one thing, that eye should always remain open, right? Our eye should always remain open. So in inevitable and incomplete abortion, the os is always open. Otherwise, in everything, the os is closed. Okay. So going back to the question, the os is open. It can either be inevitable or incomplete. Now, how are you going to differentiate in between the two? As the name suggests, inevitable means that the process of abortion has started. It cannot be stopped by anything and the patient will abort. Incomplete, as the name suggests, that the abortion has started. She has incompletely aborted. The product of conception has gone out of the uterus. So, in inevitable abortion, the uterus size will be equivalent to the period of gestation because she has not started evacuating. But in incomplete, since she has started evacuating, the period of gestation, the uterus size is going to be less than the period of gestation. So here the uterus size is 6 weeks and she has presented to us at 8 weeks period of gestation. Therefore, our answer is going to be incomplete abortion. Other important points, that had it been a complete abortion, it means that the process is finished now. So therefore the os is going to be closed, the bleeding is going to be minimal, the pain is also going to be minimal. Okay. Threatened, that the process of abortion has started, but it can be stopped. Okay, you can give her progesterone, you can give her bed rest, but it can be stopped. Okay. So the bleeding and abdominal pain will be mild. In missed abortion, what will happen? Bleeding will be minimal to no bleeding. There will be no pain. Why? Because it's a missed abortion. We are missing the diagnosis. So the patient is not having symptom. But when you do an ultrasound, there will be dead fetus or an embryonic fetus. So therefore, our answer is incomplete abortion here. All can be given in first trimester abortion except. Okay. So in first trimester abortion up to 12 weeks, we can give mifepristone and misoprost. If you give misoprost alone, then it has decreased efficacy And letrozole is something which has been recently introduced. Surgically, we can do manual vacuum aspiration or electric vacuum aspiration. Okay, so going back to the question, all of this can be given except misoprost, yes. Mifepristone, yes. In fact, mifepristone plus misoprost is a better option. Methotrexate, can it be given? No. Letrozole is something which has been introduced. So therefore our answer is methotrexate. Now few points about medical abortion. On day 1, we will give mifepristone, which is 200 mg. Okay. After 48 hours, which is after on day 3. If the patient is up to 7 weeks period of gestation, we will give her 400 mcg of misoprost. This misoprost can either be taken sublingually, which is kept under the tongue, or orally with water, or it can be kept inside the vagina. If it is kept sublingually, it has highest efficacy. But if it is kept per vaginally, then the systemic effects of misoprost like pain, fever are going to be less. If the patient is 7 to 9 weeks of period of gestation, we will double this dose and we will give her 800 mcg. So it can either be given sublingually, orally, or per vaginally. In addition, the patient will have pain, so you give her analgesic, antiemetic, and you offer her contraception. So what is the mechanism of action of mifepristone? Mifepristone is anti-progesterone. What it will do is, since it is anti-progesterone, it will not lead to continuation of pregnancy. What is misoprostol? It is prostaglandin analog. Prostaglandin E1 analog. Remember this thing, prostaglandin is different from progesterone, right? So since it is prostaglandin E1 analog, what it will do? It will increase the contraction of the uterus musculature. And whatever the product of conception is there, it is going to expel out. So that is why mifepristone plus misoprost has highest efficacy. What are the modifications as per the 2020 MTP bill? Now this MTP bill came in 1971. This was modified latest by 2020. Now there are few modifications that we need to remember. If the patient is getting aborted at 20 weeks of pregnancy, only one registered medical practitioner is required to do that. If she is getting aborted from 20 to 24 weeks, then two registered medical practitioners are required to do the procedure. So the upper limit has been extended to 24 weeks, as we can see from 20 weeks. But if the fetus has any abnormality, if the patient did not have any ultrasound done and she gets to know that she has an anomalous baby by 28 weeks, okay, so there is no upper limit for that and she has the right to get aborted. Okay, the name of the patient is not going to be revealed. So just in case if the patient is not taking home medical abortion, if she is taking hospitalized medical abortion, then her name will be registered as X, Y, and Z. All right. So this is how the form looks like. She is more than 20 weeks of period of gestation. Then two registered medical practitioners need to sign and fill the form. Hospitalization is generally required for the second trimester medical abortions. Mifepristone is given again 200 mcg orally, and after 48 hours, here misoprost is given 400 mcg every 3 hourly per vaginal, maximum up to 5 doses. What is the paracervical block position? So the paracervical block is given at the cervix so that the abortion process is not painful for the patient, and it is 4 o'clock and 8 o'clock position. Identify these instruments. So this is the Hawken ambulator dilator, this is the cervical dilators, and this is the Hagas dilator. Okay, so this is used to dilate the cervix so that our instrument can pass during the time of suction evacuation or dilatation curettage. This is the ovum forceps. We can see that this has a fenestrated end, and remember that this does not have a latch over here, right? It does not have a latch. Why? Because just in case if we are introducing it inside the uterus and we are catching hold to the uterine musculature, we can tend to pull that and the uterus can get perforated because it is very pliable. That is why we don't have a latch, and this is generally used for dilatation and curettage procedure. What is the most common site of uterine perforation and suction evacuation? So the most common site is the anterior wall, followed by the cervical canal, then right lateral wall, left lateral wall, and posterior wall and fundus are the same. With which instrument is the incidence of perforation highest? So it is highest with the suction cannula, followed by Hagas, and then the curette. So the correct answer here will be anterior wall. Well, thank you so much. This brings to the end of our inning. See you in the next match.